Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.
In today's episode, we will be talking about sepsis-induced cardiomyopathy, another episode in our sepsis series. We will be coming out with a whole bunch of additional sepsis videos, but what have we done so far? Let's see, we've done sepsis basics, septic shock basics, deeper dive into sepsis pathophysiology, sepsis phenotypes. We're now doing sepsis-induced cardiomyopathy and more to come. If you're listening on our podcast or watching this in YouTube form, just know that you can find either the video or the podcast version linked. We also will upload the study guide to our Patreon page, which will be linked in the video description as well, or the podcast description. And then we also have a weekly newsletter that is totally free, that the sign up will be in the description too. So enough of our little hype story there. With no further ado, sepsis-induced cardiomyopathy. So sepsis is one of the leading causes of morbidity and mortality in critical care. We've talked about this before, right? The mortality is variable, but somewhere between 20 and 50% for septic shock, right? These really, really sick patients. And we've improved that a little bit, but not nearly as much as I think we all would have hoped over the last couple decades. Something we're starting to realize, though, as time goes on, is that something can happen to the heart itself from this dysregulated immune response. Because those who haven't seen our previous sepsis videos, we've talked that septic shock is really driven by this dysregulated host response to infection. Your immune system that obviously is there to fight infection, we certainly need it, goes into overdrive a little bit, and it has this kind of hugely robust and somewhat dysregulated response that then can lead to, as we talked about in the pathophysiology video, massive cytokine release, vasodilation, capillary permeability, endothelial injury, microthrombi, relative adrenal suppression, some possible mitochondrial dysfunction too, multi-organ injury and all that kind of stuff. So this dysregulated immune response, just like it affects the kidneys and causes acute kidney injury, and it can cause acute liver injury, it can cause acute lung injury, it can cause kind of quote-unquote brain injury with things like delirium encephalopathy. It certainly affects the heart too. And that's kind of cueing in the topic for today, which is the sepsis-induced cardiomyopathy. Particularly, we'll talk about the epidemiology, the mechanisms, diagnosis, why it matters, prognosis, all that kind of stuff. So no further ado, starting with epidemiology. So sepsis-induced cardiomyopathy, also known as septic cardiomyopathy, can occur in actually 30 to 50% of patients with septic shock. That's the key, is septic shock. This isn't just severe sepsis or sepsis. Again, phrases we've talked about in previous videos. But 30 to 50% of those in septic shock. Now, there is a lot of variability, and this is really important because there's several different kind of definitions or diagnostic criteria for sepsis-induced cardiomyopathy, and depending on which one of those definitions you use, drives a little bit of the variability with how often this occurs, right? Because if your definition is very loose, this is going to occur more often in folks. If your definition is very stringent, it's going to occur less often. But that does not mean the disease is not there. It just means the way we are defining it is slightly different, which then drives some of that variability. The good news is, when it comes to sepsis-induced cardiomyopathy, is it is reversible in most cases. You get myocardial dysfunction, right? Myocardium being the muscle cells of the heart, and that does tend to recover once the septic shock is improving, which we'll talk more about too. It doesn't seem that there's a predilection to a different gender. It doesn't seem like it affects males or women, males or females more or less. But older adults, no surprise, do seem to have worse outcomes, as well as anyone with underlying cardiac disease. Both these things make sense, right? If you're older and more comorbid, you probably are not going to fare as well when you get damage to your heart. If you have underlying heart disease already, you're probably not going to fare as well to get kind of the second hit from septic shock. All right. It is also associated, we do know, with increased ICU length of stay, increased need for vasopressor support, mechanical ventilation, and often correlates with higher SOFA scores and Apache 2 scores. And these are two kind of risk stratification scores that help us understand the severity of the septic shock. There's been some correlation with things like morbidity, mortality, and all that kind of stuff. So the summary here, which is no surprise, is that sepsis-induced cardiomyopathy seems to cause patients to be quote-unquote sicker. Now, the counterpoint to that would be, does it cause patients to be quote-unquote sicker, or do sicker patients more often get sepsis-induced cardiomyopathy? And we'll have more discussion on that as we go through the video, although there may not be a definitive answer, at least not yet. So pathophysiology, how and why does this happen? Well, we know that sepsis-induced cardiomyopathy is myocardial depression. As most of us probably know, the heart, we're going to draw a heart on the screen if you're watching. This is the right atrium, right ventricle, left atrium, left ventricle. We know that the myocardial muscle cells of the heart, just like many cells, are affected by some of the dysregulated immune response in septic shock. Those inflammatory markers like cytokines, metabolic derangements, and autonomic pathways too. The heart is innervated in many senses by our autonomic pathways, things like the vagus nerve and sympathetic stimulators and all that kind of stuff. So these types of things all affect myocardial cell health. And this complex interplay is what can lead to myocardial cells, again, being the muscle cells of the heart, depression, which is thought to lead to sepsis-induced cardiomyopathy. Now, we use a lot of kind of big, what we consider generic statements, so we're going to dive a little bit deeper. Some of the key mechanisms. So the first is inflammatory cytokines. As we talked about in our septic shock pathophysiology lecture, this dysregulated immune response that happens in septic shock, part of that is a huge release of inflammatory cytokines. Things like TNF-alpha, tumor necrosis factor alpha, a bunch of different interleukins, IL, interleukins, 1 beta, interleukin 6. There's a bunch more. But these are thought to directly suppress and affect myocardial cell contractility. And the contractility of myocardial cells, these are the muscle cells of the heart, and how well they're contracting does contribute significantly to how well that heart is pumping blood, that heart ejection fraction. The thought is that there's this nitric oxide mediated pathway involved. We're not going to dive too deep into this. Lots of stuff out there on this, but the thought process here is that the nitric oxide leads to cGMP upregulation, which then can affect calcium influx into myocytes. Calcium, we joke that calcium is kind of nature's vasopressor inotrope, and that with decreased calcium influx, these myocytes can't contract as robustly, which then blunts inotropy. If this word is foreign to people, this is essentially kind of the quote-unquote contractility of the heart. All right. Another pathway involved is probably mitochondrial dysfunction. Mitochondria is the powerhouse of the cell. It produces energy in the form of ATP. And we know that sepsis, we talked about this again in our pathophysiology lecture, that there's some mitochondrial depression in sepsis. And part of this is from lack of oxygen, adequate oxygen delivery. But part of this might be direct cytokine effects on mitochondrial function. But sepsis impairs the mitochondria's ability to do oxidative phosphorylation. Thus, the mitochondria cannot produce enough ATP, and that leads to the myocardial cells not having enough oxygen to kind of function at their peak, and that can lead to decreased cardiac function. Another key mechanism here is autonomic dysregulation. So we've talked about inflammatory cytokines, mitochondrial dysfunction, now autonomic dysregulation. As we mentioned, the heart has innervation, nerves that affect its function, both sympathetic, being stimulatory, and parasympathetic, being blunting. And these are often driven by beta-adrenergic receptor signaling pathways and stress responses from things like cortisol. And what we know is that in septic shock, some of these pathways have dysregulation, just like our immune response is dysregulated. And the dysregulation in some of these sympathetic and parasympathetic pathways can lead to abnormal beta-adrenergic signaling of the heart, and that can then lead to myocardial, decreased myocardial function, or a dysregulated myocardial function. In addition to that, there's some evidence that in certain patients with septic shock, there's kind of relative adrenal insufficiency, meaning there's not enough cortisol being produced, and certainly that can contribute as well to myocardial dysfunction. Microvascular dysfunction, kind of the microcirculation is a big thing in septic shock, and shock in general, but particularly in septic shock. And what we know is that the endothelial cells that line the capillaries get affected by this inflammatory response, cytokines, immune cells, and it can cause endothelial activation and cause endothelial damage with capillary leak. And the coronary arteries and veins that provide oxygen to the heart, just like the blood vessels that provide oxygen, blood flow to the other organs, are affected. And that can lead to myocardial cell edema, or kind of more fluid in those myocardial fibers. It can lead to a mismatch with oxygen supply and demand, so the myocardial cells are not getting enough oxygen delivered compared to how much demand there is for oxygen. And that can then lead to myocardial injury or death. And this mismatch between oxygen supply demand, as well as some of the microvascular damage done by septic shock, can all lead to worsening cardiac function. And then last is this direct cardiomyocyte injury. So toll-like receptor activation of some of these myocardial cells. Toll-like receptors are these receptors on cells that are activated by kind of quote-unquote foreign invaders, foreign proteins, glycoproteins, lipopolysaccharides. All these can activate toll-like receptors on cells. The cells are essentially detecting that there's an invader in their midst, and these can lead to direct cardiomyocyte, all right, so myocardial cell injury, including apoptosis, where that cell actually commits suicide, it kills itself, and necrosis, right, that those cells are dying. So these are the 5 key mechanisms thought to be involved. If you go on a deep dive, there's certainly a ton of other stuff, and these aren't even that well teased out either. Some of these are debated upon, but it does provide a nice framework, being inflammatory cytokines, myocardial dysfunction, autonomic dysregulation, microvascular dysfunction, and then direct cardiomyocyte injury. The nice thing here is that unlike ischemic cardiomyopathy, which is where your coronary arteries are actually plugged, they got thrombotic disease that leads to myocardial ischemia. Sepsis-induced cardiomyopathy is not due to coronary artery occlusion. Okay, there's not a coronary artery that you got to go and stent that then fixes sepsis-induced cardiomyopathy like it could for ischemic cardiomyopathy. Right? This is a functional myocardial suppression secondary to the systemic illness being septic shock. Okay, so keep that in mind as we kind of think about the pathophysiology and the interventions that might be helpful. This is very, very different from ischemic cardiomyopathy, where you actually have a thrombosed coronary artery. This is a global functional disease. So how do we diagnose it then? We kind of talked about how it happens. We talked about how often it happens, who it affects the most. How do we diagnose it? Well, there are some clinical clues, although this is really difficult, okay? Some of the clinical clues are hypotension refractory to fluids requiring vasopressors. In our humble opinion, this is not that useful. This could just be severe, septic shock with microcirculatory dysfunction. Many patients in septic shock have hypotension refractory to fluids. It's kind of part of the definition of septic shock. So we don't believe that this is that helpful, but people do talk about it. Signs of low cardiac output is helpful, okay? So if you have adequate preload, which means the heart is getting enough kind of filling from the blood volume, so the patient is appropriately resuscitated with fluids, and despite this, they still have low cardiac output. This is a fairly good indicator that there could be sepsis-induced cardiomyopathy. Okay, and then discrepancy between vasodilation and cardiac performance. It seems like the heart is not functioning as it should compared to the degree of kind of vascular vasodilation going on. Can also imply sepsis-induced cardiomyopathy. But really you need imaging to diagnose this. And the biggest type of imaging here is transthoracic echocardiogram, or TTE. And what it will show is some global hypokinesis of the left ventricle. That left ventricle is not contracting robustly enough. But it's not just one part of the left ventricle, right? It's not that just the interior wall is down. This is global dysfunction of the left ventricle that then leads to reduced LVEF, left ventricular ejection fraction, often less than 50%, but it can go much lower, okay? But often less than 50%. The LV dilation is most likely present, which is a compensatory feature. And then a lot of these patients have a right ventricular dysfunction as well. This can be prognostically relevant, right? You have two sides of your heart, as we know. You have a right ventricle and a left ventricle. The left ventricle is often what we think about. We think about sepsis-induced cardiomyopathy, but if the right ventricle is involved too, this is biventricular failure, bi-V failure, both ventricles. And this has a worse prognosis than if it was just the left ventricle. This can be really, really, really difficult to manage. You can send biomarkers like troponin and BNP. In our humble opinion, these are really non-specific. They're probably going to be elevated, but what to do with them is very unclear, right? Troponin is probably going to be elevated because that patient is in septic shock, so their heart's working in overtime, and that leads to some degree of myocardial cell injury, which then releases some troponin, but not probably very relevant. BNP, brain natriuretic peptide, is probably going to be elevated, but this can be elevated in sepsis in general, and again is very non-specific. So we are not a big fan of biomarkers playing a huge role in the diagnostic pathway. And then hemodynamics, if you're spoiled enough to have something like a pulmonary artery catheter, also known as a Swan-Ganz, you can do invasive hemodynamics. We've talked about pulmonary artery catheters on the channel before too. You can search whiteboard medicine. What do we put it under? Maybe pulmonary artery catheter, maybe cardiac chamber pressure, something like that. And we'll put out a more specific video too if people are interested on kind of Swan-Ganz in particular. But it would show a low cardiac index, right? That would tell us the heart is not pumping out enough blood. It often has a high mixed venous oxygen saturation, and then a normal to low wedge pressure. These are really advanced topics. These might not make sense to many people out there, and if they don't, let us know in the comments, because we could put a video out specifically on these different measurement devices, if that would be helpful. But for the sake of this lecture, probably not worth us doing a deep dive in each one of these things, because they could be their own hour-long lecture in and of themselves. So the summary here for diagnostics is, in our humble opinion, really echocardiogram. In the setting of the context, the patient has to have septic shock and has to have a clinical picture that fits sepsis-induced cardiomyopathy, and then you get an echocardiogram, and it looks like their LV, left ventricular ejection fraction, is down. That's pretty consistent with sepsis-induced cardiomyopathy. All right, you do need to exclude acute coronary syndromes. These are those thrombotic coronary occlusions and pre-existing cardiomyopathy. This is probably self-explanatory, but is worthwhile saying out loud. All right, management of these patients. So unfortunately, there's no specific treatment for sepsis-induced cardiomyopathy beyond supportive care and treating the underlying cause being sepsis. Okay, there's no magic, IV medication you could push that then causes myocardial cell recovery. So the core principles related to that are you want source control, incredibly important. Early antibiotics, incredibly important. These two things make a huge difference. Make sure they don't have an abscess somewhere that needs to be drained. Make sure they don't have cholecystitis or appendicitis, which is not, or obstructive nephrolithiasis with hydronephrosis, right? These are things that won't get better without removing the source or decompressing the source. So early antibiotics and source control. Hemodynamic support, norepinephrine is still kind of our first line vasopressor, even in sepsis-induced cardiomyopathy. Now, if someone has a really low cardiac index, or there's concern that the heart's inability to have optimal contractility and ejection fraction is leading to hypoperfusion, there is some argument to try inotropic support. Mixed literature on this. Certainly no definitive studies out there that support this, but every patient's different and has not been studied in a robust way, so it wouldn't be unreasonable. And then vasopressin is a nice adjunct here. Especially if this is kind of vasoplegia dominant. Oh, it didn't like how we spelled vasoplegia, and we did not ignore that. Apologies. Fluids. After adequate fluid resuscitation, you don't want to keep giving these patients tons of fluids. That will cause congestion, and that will cause greater hypoperfusion. So just throwing additional fluids at these patients can be really detrimental, so be very, very careful. And then this is not something commonly done, but these patients can, in select cases, be candidates for mechanical circulatory support, MCS. Again, we've talked on this channel about ECMO, we've talked about intra-aortic balloon pumps, and all that kind of stuff. Data is limited on the efficacy of these things, not commonly done, but they are done sometimes, and there's probably a future where they're used more commonly. So mechanical circulatory support is the end stage of support that you can provide these patients if your institution has them and does agree to, cannulate and put these patients on pumps. Steroids are possibly helpful. Now, their role in sepsis-induced cardiomyopathy in general is a bit unclear. There definitely are guidelines that suggest steroids, stress dose steroids for vasopressor refractory shock or fluid refractory shock, and we'll put out a separate video on that. So stress dose steroids should be in the back of your mind. And then beta blockers is something people talk about. This is very controversial. Our humble opinion is that the evidence to date does not support using beta blockers to control the heart rate in patients with sepsis-induced cardiomyopathy, but you will hear things out there and read studies on it. And of course, this is not medical advice, but that is our humble opinion. All right, what's the prognosis? You've done everything you possibly can to manage these patients. Well, the hallmark of sepsis-induced cardiomyopathy is its reversibility. All your hard work, all your supportive care in treating the underlying septic shock, most patients will recover normal cardiac function within 7 to 10 days. So a lot of times they need an interval echocardiogram, an interval TTE, to prove that their LV ejection fraction has in fact recovered, okay? Now, sepsis-induced cardiomyopathy does increase short-term mortality. We know that from studies, particularly if there's biventricular failure, right? That there's left ventricular dysfunction and a right ventricular dysfunction. So we know that this increases mortality when you do have it, but we also know if you can bridge someone through that kind of first week or two, that this should recover as the septic shock improves. Longer-term studies suggest that patients who survive sepsis-induced cardiomyopathy don't necessarily develop chronic heart failure. There's certainly more to this, right? There's remodeling that occurs to the heart when you have sepsis-induced cardiomyopathy that may increase your risk for chronic heart failure down the road, but it's not well teased out. It's not well known. And then, as we mentioned in management, early recognition and aggressive supportive care for these patients is absolutely critical. So, in conclusion, sepsis-induced cardiomyopathy, it's common, it's reversible, but it is clinically significant and it does increase mortality and it is incredibly hard to manage. It reflects kind of the systemic toxicity to the myocardium. This is not thrombotic ischemia. This is not coronary occlusion. This is kind of systemic global hypoperfusion and direct injury to those myocardial cells. And then echocardiogram is your best tool. Use echocardiogram, support the heart, treat the infection, reassess often. These are all crucial concepts. All right, hopefully that was interesting. More advanced lecture on sepsis-induced cardiomyopathy. Super interesting topic, something there's probably going to be a lot more work on in the coming decade, and we'll know more, so stay tuned. Let us know what thoughts, comments, questions you have. If you are watching this as a YouTube video, check out our podcast channel. If you're listening to this as a podcast, check out the YouTube video. Also, we'd love for you to check out our Patreon page. We'll put this study guide on the Patreon page as well as practice questions, and then we have a free weekly newsletter as well. All that will be linked below this episode. Either way, stay well. We appreciate you all. Keep learning. We'll see you next time.